Hey, everybody. Welcome to the GBNO Show, podcast number 10. I am Dr. Rob. This is my awesome wife, Shannon, the dietitian. Say hi, Shannon.
Hi, Shannon.
You did it again. I love it. Okay, hot topic today, yesterday, last week, last month, probably for the last 6 months.
Yep.
GLP-1s, or some of the names that are in the industry.
Well, actually, can I correct you?
Yes.
GLP-1 agonist.
Yes, exactly. Okay, so GLP-1 agonist, Ozempic. What else?
Mounjaro.
These are semaglutides, right? They were brought on originally for diabetes, from what I understand.
Type 2.
This is not my specialty, so Shannon is going to be your main host today. But they are huge because people who were getting prescribed these medicines for type 2 diabetes were losing good amount of weight.
Correct.
Good amount of weight. Losing a good amount of weight. So the prescribing practitioners were going, hold on a second. Maybe this isn't just good for getting people off of their diabetic medication, like metformin or whatever else. They're losing weight. So we're going to talk about all things GLP-1 agonist today.
Correct. Why don't you start by reading what is GLP-1 and why did they create a drug to mimic GLP-1? Because that does occur naturally. It is a hormone that is released in our small intestine as a natural occurrence to when somebody eats. So we all secrete GLP-1 hormone as a response to eating.
Well, it's funny you say to read it because somebody I know actually put a script in front of me.
That is right.
So
read what you're told.
Yes, dear. The GLP-1, glucagon-like peptide 1, is an agonist or peptide, not hormones, but they mimic the action of a naturally occurring hormone called GLP-1. What is a GLP-1, Shannon?
Well, I just mentioned that. It is a hormone. The agonist itself is not a hormone. It's peptide that mimics the hormone. Okay, so we have GLP-1 receptors all over our body. And we're going to get to why that's significant later on when we talk about like the benefits, the clinical benefits of this medication, because it goes far beyond just type 2 diabetes and obesity. They are noticing other health benefits as a result of this. And we're going to get into that.
So let's talk about the word agonist. If you know somebody who's an antagonist, that's somebody who's always trying to needle you, start an argument. In my world, an antagonist is the opposite to something. So if I flex my bicep, the bicep is the agonist, the tricep is the antagonist that opposes. So the GLP-1 agonist is basically this peptide that is going to activate a system.
Basically, what it boils down to is we do have this naturally occurring. However, it doesn't stay activated very long to make that big of a difference in diminishing your appetite. These were found from a dinosaur or some type of, I forget what the name of it.
Dinosaur?
Yeah.
I thought those died millions of years ago.
What is it? Oh, God, I'm going to totally blank on the name of, it's like some monster.
The Komodo dragon.
No.
The Godzilla.
It's going to be in the show notes because this is going to drive me crazy now. But anyway, they found it in said monster that this is where it comes from. This is how they realized that it works.
Really?
Because of the duration that it sustained the benefits, not just quickly like our bodies does. And so this is kind of where it came from. I'm not doing a very good job of explaining. Like an alligator or crocodile?
Because they only eat, I think, once every week or something.
It is definitely 100% has monster in the – it's almost like Helica galacta monster. Helica monster. Eric's doing sign language to me.
Eric.
Gila monster. Gila monster.
What's a Gila monster?
Eric, what's a Gila monster?
Let's Google this.
We're going to Google this.
Yeah.
Okay.
Can you be like young Jamie on Joe Rogan? Sure. Let's do it.
Okay. A Gila monster. There you go. this is where it originated. This
Okay.
is where they figured out the mechanism of action with it. The GLP-1 sustaining in your body makes a difference. So let's just talk about what the roles it plays when these agonists are in your body.
Okay, so that is a great segue to the second bullet point here, which is, I'm going to read it again because this is not my field. It plays an important role in glucose regulation. You can talk to that. Slowing gastric emptying, reducing appetite, and stimulating insulin secretion while suppressing glucagon release.
Okay.
Let's hit all those points because that sentence right there, I think, will explain everything.
Yeah, well, so this is why it launched as a medication for type 2 diabetes. It's really known to be proficient in managing insulin. So,
Okay.
We'll review. When you eat anything, it turns to glucose in your blood. You need your pancreas to secrete insulin to go and get the sugars and put it into the cell so that it can be used the way it's supposed to.
Mm-hmm.
When people have type 2 diabetes, that mechanism is not proficient. So this drug helps that be more proficient.
Right.
The other thing that it does too is it helps with what we call satiety. So it helps you feel fuller, faster, for longer. And what you just read there, by reducing appetite, obviously there's a lot more physiology that's involved here, but I don't really think any of our listeners really care about that. It's a combination of all of these things. Better control of your glucose and insulin, reduction in your appetite, longer sustainable satiety. Satiety means satisfied, content. Imagine if you've just eaten a turkey dinner at Thanksgiving, how full and content you are.
Yep.
Excuse me. It helps with that longer term.
And then gastric emptying, for those of you who don't know what gastric emptying, it kind of makes sense by its name. It's literally your stomach emptying.
So it slows down that peristalsis wave-like process in our intestines that are propelling the food through. It kind of slows that process down. Absorption slows down. And we'll get to this when we talk about side effects because this can then trigger people. There's a lot of misinformation on the whole side effects of the medications as well. But all of that combined is what equates to people eating less calories.
Right.
I mean, that's what it boils down to.
So these agonists, again, like I said before, an agonist is something that activates. So these GLP-1 agonists they light a fire under, not a literal fire, but, verbiage being what it is, they basically activate a system that does everything you just mentioned. So you eat a bite of food, you eat a bite of food, it goes down your esophagus into your stomach, you eat a few more bites. Now, instead of your stomach emptying that food into the next phase of digestion, basically it takes a little longer for that to aid. So your bucket, if you will, is filling up quicker. So now you're feeling fuller, so you don't want to eat as much. So you're consuming less calories at any given time that you sit down.
But one of the things that's important to mention is that there's a brain link here too. Mm-hmm. So, and this is something that they're really looking into more so for addictions, et cetera. But, it's all of a sudden people really aren't thinking of food, obsessing about food as much as well. And that's because we have those same GLP receptors, those same receptors are all over. And that's why we're seeing other clinical benefits come from these agonists because it's really helping all over.
Okay. So just to build on that, how you get these kind of sugar responses in your brain. So if you eat a little piece of chocolate and you go, oh, that's really good. And then it triggers a response in your brain going more. So
we really don't know just quite yet how, the mechanism. It's not the reason it launched. These launched specifically for type 2. But
I understand
now
that.
As we're starting to see studies coming out for more longer term use, this is where we're seeing these other health benefits start to surface. So that is something that we will talk about maybe on a different one, but I really don't know. What it's doing is making you think less about food, obsess less about food, and helping you feel fuller, faster, for longer, and also from a metabolic standpoint, helping you to be more proficient with your insulin and glucose. And in a nutshell, that is how it's working.
Okay. We talked about a hormone called glucagon, which I know what it is, and I can explain it.
Go ahead.
I want you to, though.
No, you go.
Well, glucagon is released to help mobilize. Okay, so when you eat a carbohydrate, let's say you eat a piece of fruit or pasta, it's a chain of glucose molecules. You start to break it down in your mouth with salivary amylase. It goes down your esophagus into your stomach. Your hydrochloric acid breaks it down, and then it goes into your duodenum, which is your first phase of real digestion or first phase of real absorption. You get a triggering of glucagon, which glucagon basically will mobilize in an exercise state anyways. It will mobilize release of that. Well, I got ahead of myself. So when you start absorbing the glucose from that pasta or fruit, it goes into your muscle. Your muscle has storage, and that storage is called glycogen. So those glucose molecules rebond, and then they go into your fuel tank in your muscle in the form of glycogen, but your liver also has stores. In an exercise world, glucagon is released to mobilize liver glycogen so the muscles can feed on it during exercise, so you're not burning out all the muscle glycogen. So tell me the glucagon effect on GLP-1 agonists.
You know what? I honestly don't know. It just suppresses the glucagon release. So I'm not really sure what you're going for there.
Again, I went down the rabbit hole in physiology. Sorry, I'm a dork. But so during exercise, glucagon will basically affect your stored glucose, which is in the form of glycogen in the liver, to release it to give you energy. But that will push glucose into the bloodstream. And a lot of times with diabetes, you've got too much glucose in the bloodstream already. So the GLP-1s like Ozempic basically inhibit that glucagon hormone, so you don't have a lot of extra blood glucose floating around in the system. So it's controlling insulin, so you're not going to get those huge spikes. It's controlling glucose, not insulin. It's controlling glucose in the system, so you're not going to get those huge insulin spikes, and you're not going to get a crash after you eat. So it's regulating a lot more than just appetite. It's actually affecting how your mechanics work, if you will, with regard to your blood glucose release.
And then to kind of answer a little bit more on the brain involvement, it's the hypothalamus.
Okay.
So that's what we know is your eating center in the brain, if you will. So it's just proficient at the signaling of when to stop.
Yep.
So when to eat, when to stop.
Yep.
All to do with hunger mechanisms.
So it's shutting off the switches that say eat, eat, eat.
Exactly.
Click,
yeah.
off.
So, exactly.
So the lizard. Tell me about the lizard.
Okay. Eric did this for us.
Young Eric figured it out for us.
Oh, hold on. I got to get my glasses on. Okay. So the Gila monster, it's not a monster. That's good.
I was hoping there was
because they are real.
I was hoping Godzilla would be still around.
A venomous lizard. It's not a dinosaur. Native to the southwestern United States and northwestern Mexico. Northwestern Mexico. Okay. So it's a heavy, slow-moving reptile.
Well, I'm glad it's heavy and slow because if it's venomous, I want to be able to get away from it.
So let's see what it says about diet. The primary food source of a Gila monster is eggs of birds, lizard. Okay, that doesn't make any difference. Well, anyway, this is, for whatever reason, I don't know why somebody would have been interested in said Gila monster, but this is where the medication originated.
God, that is wild. Who thinks to study that? I'm going to study that lizard and see what its digestion is like.
I mean, we do need to, that's probably it, right? Like they probably realized that they have a sustained GLP-1 where we don't.
Yeah.
And that's why They recreated that. Whatever's happening in the Gila monster is now happening in humans.
So no beer bellies on Gila monsters.
No.
No type 2 diabetes on Gila monsters.
No.
You're probably getting sick of the dad
We're
jokes,
digressing.
right?
Okay,
Yeah.
so let's talk about
jokes, sorry.
a little bit about their history.
Yes.
Because people have asked me time and time again, there's a lot of misinformation, one, about these medications. They have been around for a very long time. For 20 years is when their inception happened. Byetta is the first one. I even remember it for type 2 diabetes. Then Saxenda really was the first one for weight loss.
And this is when, like late 90s, early
2019.
2000? Okay.
So that was when the first weight loss happened. Ozempic really was before that, but it was for type 2 diabetes. Then it's the same molecule, semaglutide. The thing that happened is they launched it as Ozempic for type 2 diabetes, and then once they got the indication for weight loss, they launched it as Wegovy. And so that's the confusion. It's the same molecule, same exact thing, same dose, same pens. It's just two different names. One's meant for people who have type 2 diabetes, and one's meant for people.
What do you mean pen? Is that the application?
It's how it's filled, pre-filled pens that you. Well, Saxenda was daily. You had to give yourself a shot in the abdomen daily. Ozempic was the first once a week injection. Okay. So that's just a little bit about the history. Then we've now launched tirzepatide, which is not actually a GLP-1 agonist. It is actually, it's two. It's both that and what they call GIP. So I'm going to read what that is.
GIP.
It is a glucose-dependent insulinotropic polypeptide.
Okay.
So that launched as Mounjaro for type 2 diabetes, and then it now has the weight loss indication under Zepbound.
Gotcha.
Okay. What we do know about the difference between the two is that tirzepatide, we are seeing larger amounts of weight loss. That extra peptide has become proficient. Like we are even seeing levels of weight loss that are you would liken to bariatric surgery, which is pretty amazing.
And bariatric surgery being stomach stapling, if you will, lap banding, where they literally surgically go in, and if your stomach is this big, they sew it down, so it's there's a lot of different variations, but they make the stomach sometimes a quarter of the size. So you literally eat 1/2 of a cup of yogurt, and you're so full you physically can't put anything more in your body.
So anyway, we see a lot, upwards of 50-pound weight loss being quite normal in bariatric surgery, and that is what we're starting to see. Definitely way more than the 25 pounds that Ozempic and Mounjaro, or not Mounjaro, but Wegovy have. With Mounjaro and Zepbound, we're seeing over 35. Like the benefits are even beyond 35 pounds.
Wow.
Yeah. Okay. So let's get into, so that's a little bit about their history. I want to get into, so let's review again what it's doing and how it's working. Better blood sugar control, enhancing insulin secretion, inhibiting glucagon release, which you went over, slowing gastric emptying, slow the rate at which food leaves the stomach. You talked about that, reducing appetite, and then acting on the hypothalamus to make you not think about food all the time. Yeah. And then once food hits your stomach, it triggers, okay, stop.
So the thalamus and the stomach kind of communicate.
Yeah, exactly. So that is all of those combined effects equal weight loss. Yep. That is why it's working. Okay, so now let's talk about the other clinical benefits that we are now seeing as a result of the fact that there are GLP receptors, not just in, you know what I mean? Like they're all over the body. It's not just weight control. It's not just glycemic control. There are cardiovascular benefits that they are seeing. And that's great because most people with type 2 diabetes do have cardiac issues as well.
But we see that too with people who are type 2 diabetic. Typically, now there's going to be situations where people are just genetically prone to type 2 diabetes, even though they tend to be leaner. But, typically with your type 2 diabetes, it's going to be a steady onset of weight gain. You're going to have more belly fat, a little less muscle mass. You're going to be a little more sedentary. So with all of that comes the comorbidities associated with type 2 diabetes, which are cardiovascular diseases like high blood pressure, atherosclerosis, which is, the fatty accumulation and plaquing in the arteries.
Yep. And
when you address type 2 diabetes naturally, you tend to see improvements in those cardiovascular states. But this is just happening faster now, correct? Because of the GLP-1s and GIPs, right?
Right.
And did I say that right? GIP?
GIP. They call them, I think they're GIP.
Okay.
That's what they say.
Well, GIP spells GIP.
Yeah, it does.
See how that didn't blow over my head? I'm pretty bright.
It's actually been shown to cause a decrease in CVD events. So cardiovascular disease is...
CVD is cardiovascular disease.
So we're talking stroke, heart attacks. So that's significant.
Yeah.
It's actually neuroprotective because remember, we know it's affecting in the brain, but it's actually been known to be neuroprotective in inflammatory diseases, which is amazing.
Now, neuroprotective meaning when we have type 2 diabetes, we don't have great perfusion of blood, which means blood getting into the brain, which means glucose getting in the brain, feeding the brain. So now a lot of Alzheimer's and dementia, they're calling, or cognitive decline as we age, they're calling type 3 diabetes. Neuroprotective basically means you're protecting the nervous system, the brain, spinal cord nerves, etc.
Exactly, which that is amazing. Like that, I feel like this is an area that we're just really going to see a lot of taking from what they're seeing here, and now we're going to see spin-offs of other things for different disease states.
Yeah.
The other thing is improved liver health, which we need because we are in a state of panic with the non-fatty alcoholic liver disease that is absolutely becoming epidemic, unfortunately. That's a big one because we are now seeing non-fatty alcoholic liver disease a lot more, even in young children. Now, I do not believe in this being prescribed for young children. However, I'm just saying because of how terrible the unprocessed our diets are, we're now seeing issues with liver. So the fact that it can improve liver health, believe me, as a society, we need this.
I was just reading a story about how we're starting to see, when I was in school back in the early 90s, you had type 1 diabetes, which is insulin dependent. You're born with it. It's an autoimmune disorder. You have to take daily insulin. And then we were taught way back in 91, 92 that type 2 diabetes was adult onset diabetes. Well, we stopped calling it adult onset diabetes, 10, 15 years ago, 2008, 7, 8, 9, somewhere into there, because we had so many cases of, unfortunately, young children getting type 2 diabetes, 9, 10, 11-year-olds, because our food system is so crap. So now we're seeing fatty livers in kids that age as well. So we have a major food problem, nutrition problem in our society right now.
Yeah, and that correlates with what I do for a living with obesity prevention because I do pediatrics and adolescents, and clearly it never really was an issue when we were young. It was rare to find an obese child.
Right.
And obviously, it's sadly much more prevalent. Okay, so I'm going to keep going on the clinical benefits. PCOS, which a lot of women are dealing with, which can lead to issues with, getting pregnant, et cetera. So that's amazing. And this is really...
Hold on, smarty pants. PCOS, polycystic ovary.
Yeah, go ahead. Polycystic ovarian syndrome.
Okay.
And we see this commonly in young women who typically are overweight or have obese issues that then have problems with conceiving. I'm not going to get into the details. Hypertension, GI health, mood and anxiety disorders, vascular health. So it's going far beyond just what the diabetes and obesity, and that makes sense because we know that obesity affects way more than just one thing, right?
Yeah, absolutely.
Obesity affects your entire health. Okay, so the dosing, they're pre-filled pens that have dose that you titrate up. So you have an initial dose, and then 4 weeks later you titrate up and as people are titrating up, it's quite common that they will have some side effects. What I have seen in the over 10 years that I've been working with patients on these is that once they get to where their body has adapted, the side effects go away.
What are the side effects?
Nausea. Some people get reflux. Some people have issues going to the bathroom, so constipation. This is where there's just this whole myth of people who think that it's going to cause a bowel obstruction. I assure you that if you already have horrible eating habits and you get on this medication and don't correct your eating habits, you're going to have issues going to the bathroom. Mm-hmm. So I'm going to get into the reasons why this works and this doesn't work. And I'm also going to get into why people are experiencing regain. Mm-hmm. And that's really what I want to spend the majority of the time on. But I'm just giving everybody a little bit of background about the medications. The dosing is a schedule. And those are for the pre-filled pens, and these are for the brand names. But what everybody's going to start hearing about, if not already seen, is they are now compounding these same molecules. So it's semaglutide and then tirzepatide. They are now compounding these in compounding pharmacies. So what that means is the pharmacies themselves are taking the molecules, they're buying the molecules, and they are putting them in their own doses in pre-filled pens. Some of them are giving injections. Now I'm starting to see some oral doses. The thing you have to be careful with on compounding is that you have to make sure it's a legit pharmacy that does compounding in a way that, again, this is off-label use, right? Like this isn't, the FDA has not approved the use of what they're doing, so that you have to first know that this is off-label.
The doctors are still prescribing it, though.
No, they're getting these through the pharmacies. Just like they'll have a medical director on staff that's seeing people telemedicine who basically say, okay, yeah, you've been seen by a doctor, and then now I'm giving this pharmacist the ability. It's not so much that their own personal doctors are calling this in. These pharmacies and these vitamin shops, like we have one in our local mall, are doing this through doctors who are just seeing people telemedicine and saying, yep, I give you the go-ahead.
Go to ABC Compound Pharmacy and not a personal prescription, just go and buy a bottle of this stuff or whatever.
No, the pharmacist is still disseminating it and still doing, but you have to understand that there's no one, it's off-label. So those pharmacists can do whatever they want.
Okay.
That's the importance of finding a good compounding pharmacy if you're going to go that direction.
Okay, but there's no oversight from a medical expert on that.
Supposedly there's
a drive-by.
Yes, exactly.
Right, but there's not like a regular check-in monthly to see how you're doing or anything like that.
Some have higher standards than others. And that's, now we're starting to see spas. Not starting. This has been going on for a while. Spas, like where you've got a dermatologist downstairs and all of a sudden they're the medical director. They don't have time to look in on that stuff.
Wow.
Yeah. So this is why you need to be educated, which is why I went through this so that everybody understands. I believe in my heart of hearts that this is a very safe, very, very beneficial medication, but you have to be educated and smart about how you use it, and that's the purpose of this podcast today.
All right, quick break from the podcast. So, a couple questions. Miss Shannon, from one of our awesome viewers, what are some GBNO approved supplements? That's actually a really good question.
Yeah, so let me see if you agree with me on this, because we are GBNO.
Mm-hmm.
I would say fish oils are one of the most positively studied supplements. I've never seen anything negative said about supplementing with fish oils. Would you agree?
100%. They just need to be sourced properly.
Correct. You want to speak to that?
don't buy the stuff that is on sale at a big box store because it can be rancid. You can burp it up and it's not very good for you. I use a brand called Nordic Naturals. I believe it is out of Northern Europe. And I've been taking, and again, I would recommend you talk to your healthcare professional about dosage for yourself. But I take north of 2 grams a day of EPA and DHA combined for my size and for what I'm using it for. And I never burp it up. It never refluxes on me.
Yeah, I think it's important to start with telling everybody it's super important that you, when buying supplements, because it is an industry that is not regulated. Okay, so that means they can put anything on the label and they can put anything in the pills. There's nobody watching what they do. There are companies that are reputable that do what's called third-party testing, meaning they send their product to a third party and say, hey, test what's in here and you make sure that what we're saying is in here is in here. Look for that.
Yeah, you'll see a little black label. NSF, I think, is one. I can't remember the other. But if you have 2 or 3 third-party stamps on that bottle of what you're buying, that's what you want to go with. Okay, what else you got?
Well, I really believe vitamin D is a good one to recommend. That, or just make sure you are getting out and getting really good sunlight without sunblock daily. They say 15 to 20 minutes of really good. I mean, I recommend everybody go on 3 10-minute walks a day, morning, noon, and night anyway. So that shouldn't be difficult to do. But if you feel like that is not happening, then I believe in vitamin D supplementation. Again, the dose depends on how deficient you are. So I think it's important to mention here that just because the supplement has a dose on it, it does not mean it's the dose that's going to improve your. So let's say your vitamin D is super low. Perhaps you need to double or triple the dose to get that up, versus if yours is already up and you're just trying to keep it up, your dose would be different. So just understand that the dose that's on the bottle is not necessarily the therapeutic dose or changing anything physiologically. So make sure you get some recommendations from your healthcare professional on that.
And also your vitamin D should be contained with K2 because without the K2, you cannot absorb it properly. So the vitamin D I take from Transparent Labs, which if you use code Dr. Rob, you get 10% off. But it's vitamin D plus K2. Okay, what else we got?
And then a magnesium. I'm a big fan of magnesium because it's related to about 600 different enzymatic processes in your body. It's a mineral that's very commonly deficient, and it's only good can come from it, honestly. So Magnesium Breakthrough is a brand that I mean, how many times have I recommended it to you and your patients?
Yeah.
My patients, it's been life-changing for a lot of people. I really recommend it at bedtime. I think it improves sleep. It helps muscles relax, helps with people who have problems going to the bathroom, which is nice. So I just think it's a good mineral to take.
It's also been proven to help with anxiety. It's called an anxiolytic. Some psychologists recommend it. But again, take it at bedtime because it is a calming agent. So you don't want to take it right before you go to work and fall asleep at your desk, or worse, driving to work. Okay, one last one.
A probiotic. I feel like microbiome is such an important part of our health. And there's a lot that we do to mess that up. So I think it's just a good insurance policy to make sure you're taking a good daily probiotic. Again, that third-party testing is super duper important. So making sure, one, if the bacteria, if that is feeding your microbiome is not getting to where it needs to be to make a difference, then you're just wasting money. So you got a reputable company is important. Okay, so Dr. Rob, your turn.
Yes.
I hear you talk about, this is a listener saying this, I hear you talk about a mobility workout frequently. What specifically are you talking about?
Okay, so in the GBNO protocol, I combine a lot of mobility. On a lot of the programs I write, I combine mobility. And on my weekly personal programs, I combine mobility. Mobility is a set aside day just to work on how you move better. It's that simple. So I do things like I use bands to hook onto my shoulders and I move my shoulders around. I hook bands to a squat rack. I go into deep, long line stretches. I do hip mobility work like a hip airplane. So it's really a day set aside to make sure my body, muscles and tendons, yes, but also joints are centered properly and move properly. So I'm recovered in a really good fashion so I can go ahead in the next subsequent days to actually do a really good hard workout. Because if you do a workout and you stiffen up and you don't lengthen out tendons and make sure your mobilization is good and your movement and flexibility is good, you're going to actually tighten up. And we always say if you lose ranges of motion and you can't move through a good range, let's say this is a normal range here, but you only do this on your range of motion, that's dysfunction. And we always say you don't want to strengthen dysfunction. So a good mobility routine is super important to work into the program. And it's just so you can move better. It's really that simple.
And that's a protocol you have, correct?
Yeah,
okay.
Absolutely.
Great.
Absolutely.
HeyDrRob.com.
There you go.
All right. Now back to the podcast.
Okay, shameless plug. Don't you have an Ozempic protocol that you've developed?
I do.
Okay.
So, and the reason I developed it is because I used to run the nutrition for a very large weight management program. And we were using these drugs a lot. And if their prescription is not coupled with intense education so that people understand how to modify their lifestyle, unfortunately, you're not going to see the same results that, some people say, wow, my friend got this results. We have actually a mutual patient who did not lose any, maybe 10 pounds on it. There are other metabolic factors that can be involved. However, education has to be paired. Well, then I start thinking, my gosh, this goes way beyond just the clinic that I'm doing the nutrition for. These are now being prescribed all over the world, and nobody's getting the nutrition that they need, the lifestyle change that they need, the education that they need so that they can sustain their results. So I created a 31 video program, start to finish, on anything anyone needs to know about how to change their lifestyle so that they can get the most benefits out of the medication. And then I'm teaching you how to change your life and how you're eating in a way that's mimicking what the medication is doing for you, because we have GLP naturally, right? So I'm teaching you a way to balance your meals so that you're taking advantage of how to trigger that GLP naturally so that eventually when you get off the medication, you have that mastered and you don't experience regain.
Where can people find that?
Well, in a pinch, in a minute, right now is HeyDrRobNutrition.com, which is my website, and all of my programs are there.
Okay.
And we'll put that in the show notes.
Okay.
Okay. So we were talking about compounding. Just be educated about and make sure that it is a reputable compounding pharmacy. Like you and I know someone here in Sarasota that is very well respected. A lot of functional doctors use him. So just make sure, and I even know one in our hometown where we used to live. Just make sure if you are getting this in a compounded dose that it's reputable. What's the benefit of the compounding versus the pre-filled pen? Well, here's the deal. Unless you have the proper diagnosis to take these particular medications, your insurance is not going to pay for it. So I want you to think about this, because recently we have learned that our daughter, who is a senior at the University of Arkansas, has friends that are tiny, maybe a size 4, that want to go to a size 0 and are taking this. Okay. So we know for a fact that there's no way that they qualified for insurance, which means they have found a place to get it out of pocket. And at one point, I'm sure they were paying close to $1,000 a month to get it. Now that the demand is so high, those costs have come down. I just recently helped a family who is getting tirzepatide at a compounding pharmacy, and they're getting it for about $300 a month. So that's about what the norm is right now. There are some people who are going and getting lower doses, and they're having to go and actually get the injection every week in the actual clinic or at the pharmacy.
And so these people who are doing these in these spas or these fly-by-night places thinking it's just a weight loss medication, they potentially could be the ones with the side effects, because if they're not being taught the lifestyle changes needed as far as nutrition and stomach emptying and all that, they're the ones who could be dealing with some of the negative side effects of this.
Absolutely. And they're also the ones that are going to run out of money to pay for it, and they're going to stop taking it, and they're going to gain all the way back. I mean, it's just that simple. This is not a medication you get on and off quickly. This is all about being on it long enough to let your body reset, and we're going to talk about that. So we better get going.
Okay.
Because we have a lot to talk about.
I'm going to let you go, but I was going to actually ask what's a good length of time for somebody to be on this to see benefits that actually sustain?
Well, so we always have said no less than a year, okay? But the truth of the matter is you have to understand physiologically fat cell metabolism, okay? And I teach this in my protocol because people need to understand that fat is protective. We live in caves, right? That's what your body thinks.
Ish.
And not enough time has gone by where that's not how our body has adapted to where we are currently. So fat is obviously, it protects your internal organs, but also it's huge for protective. It doesn't want you to starve. So if all of a sudden you've taught your fat cells, let's say you have been the size that you are for 5, 10 years or whatever, you've taught your fat cells that being that big is normal. And that's how it protects you, by keeping your fat cells that big. Well, you all of a sudden shrink it. And let me tell you, these medications work, and people are losing weight quickly. And then we're going to talk about the importance of when you are losing weight quickly, no matter what diet you're on, some things you have to do to make sure that you're not losing muscle. But for the purpose of fat cell metabolism, I'm not going to go there right now. But so those fat cells are freaking out because it's like, oh my gosh, she's starving. Okay, so I better give her increased appetite, and I better slow down her metabolism so that she gets out of the cave and she starts hunting for food again. And I don't want her to burn a bunch of calories while she's out hunting, so I'm going to slow down her metabolism.
So again, so people are square with this. When you're saying they're protective for energy, because fat is basically a form of stored energy. Sure. So if you haven't eaten in a while, this is like bears or squirrels going into hibernation, eating a bunch of stuff, getting all fattened up, sleeping for 3 or 4 months, and metabolizing that fat as fuel to continue the processes of living, basically. So what you're saying is a little bit of fat in there, sustained energy, but now all of a sudden you're burning it off so quickly that your body's going, oh my gosh, we need more of that. It's going to hyper store what you put in if you're not careful, correct? Am I getting that right?
Well, not so much hyper store, but the two things that you would not want to happen to prevent regain is increased appetite while your the metabolic rate is lower, meaning you're burning calories slower, yet your appetite is doubled.
Yeah.
Okay. So that's on purpose. Like, it's supposed to give you the energy you need to go out and hunt. And because this is all about preservation, right? Like, you're trying not to starve. Your body doesn't understand that we can get chicken nuggets through the drive-through. I mean, it's just how we are physiologically. So that is why it's important to be educated on, okay, I've lost all this weight. How much time does my body need to adapt to where I am, where it understands that I'm not starving? You don't need to lower my metabolic rate. You don't need to increase my appetite. I'm good. I'm healthy. That's a state of homeostasis. I think a lot of people know what that word means. It's just a point of well-being. You got to let your body adapt. Everybody's different. It could be anywhere from 1 to 6 years that it takes your body that time to adapt. But I teach this in that protocol of if you've changed your lifestyle to match what the drug is doing for you, and you've mastered the way to balance your meals where you're triggering your own GLP, right? Mm-hmm. And you've got the workout and everything down, and you are aware that you are going to have an increased appetite and a lower metabolism for a bit until your body, well, you're not going to be in a hurry to get off of it. Mm-hmm. There is a way perhaps to lower some doses and it not have to be at such a high dose. We're starting to see more and more studies on longevity. Like how is it that we really get proficient on people not regaining? But I'll tell you, anybody who has worked with me, who has done my protocol, do not experience regain because it is proficient at managing everything that they need to know. And the biggest thing is you cannot get in a hurry to get off the medication. Mm-hmm. So then if you say to me, well, I can barely afford to be on it a year, it's probably not the best fit for you then. Mm-hmm. Because what's the point of being on it and losing the weight and then gaining it back?
Yeah.
The medication, I really like using them because it makes my patients really good students. While they are learning and adapting to this new lifestyle and getting very proficient at this new way of living, the medication is taking the edge off the appetite and the lower metabolic rate, if that makes sense. Mm-hmm. So it's a tool. It is not an answer to obesity. It is a tool that, if used properly, can work very, very well. I just want people to understand that this is not the end-all, be-all for everybody. You can't eat the standard American diet and sit around on your tush and think that this is going to be your miracle. It's just not the way it is.
Right. And that comes into one of my biggest things is muscle building associated with this.
Let's talk about that.
Let's talk about that.
Yeah.
So, okay, from what you're saying, we know that your fat cells are going to shrink and you now have a little bit less energy stored in your body. So if you go to start moving and you don't have a lot of fat, guess what your body's going to break down? It's going to break down that muscle. And we know over the age of 30, we have somewhere in the neighborhood of 6 to 8, 7 to 9% age-related sarcopenia, which is muscle loss due to aging. So this is where the yo-yo diet kicks in. So, this was a thing back in the 90s when people were going on the grapefruit diet or the this diet or the that diet. They would lose weight because they would change what they were doing in their lifestyle. The weight would drop off, but then what would happen is they would have lost muscle mass. The metabolism slows down, and your metabolism is just your car idling. Okay, that's your homeostasis. That's your metabolism. That's just what your car needs to do just to kind of keep it up and running. If that lowers down to below, let's say, a 1,500 calorie burn per day, so when you have that basic metabolic rate that is now slowed down, what's going to end up happening is you're going to go, oh, wow, I went down to whatever your goal weight was. I'm down to 120. Woohoo, let's start eating again how I wanted to before. Now what's going to happen is your metabolism slowed. You've got less muscle mass. And muscle mass is what? It is an engine. It burns calories. Every time you contract a muscle, it burns a calorie. So you're using an energy source there to create movement out of this big V8 engine. Well, now you've taken this big monster V8 engine. Now because you've lost some muscle mass, it's a 4-cylinder or a V4 engine. Well, guess what? You're putting in that same food that you were before, and guess what's going to happen? You're not going to metabolize it. You're going to store that fat again.
Well, and it's really important to clarify that any diet, not just the use of GLP-1 agonists, any diet where somebody has lost weight quickly, it's going to be at the expense of muscle.
100%.
If you are not eating the proper amount of protein and you are not doing strength training.
Yep.
So what you're talking about is the fact that you've got to keep the muscle on board to counteract that metabolic. So if your body is like, whoa, our energy source is way low because we've lost a lot of fat and it's lowering your metabolic rate, how you counteract that is by increasing the muscle to keep your muscle mass up and your metabolism up.
Right.
Correct.
Because when you have more muscle mass, you now have a bigger engine that is now revving even at rest, at idle. And that's burning calories
while you sleep.
While you sleep.
Yeah.
And that's why certain types of exercise are super important. So do you want me to get into that a little bit?
So let's back up just a second because I want to start with food and the protein part of this.
Yep.
It's super important, one, when you are starting any diet, not just, the use of a GLP-1 agonist, to assess your metabolic health. In other words, if you are not sleeping, you are super stressed, and your microbiome is all messed up, let's start there. I mean, no amount of medication is going to be able to compete with those three huge metabolic guys and hormones. Let's just throw that in there, adrenal stuff. So we got to start there. Everybody should, and in my protocol, I teach everybody to kind of analyze your metabolic health before you get started. That's really important. You need to correct those before you spend the money on getting on a GLP-1 agonist. Yeah. That's for any diet. Then it's all about how do I properly eat that's going to enhance what this medication is doing. And then how do I eat long term? So we focus on nourishing because here's the deal. Your body's miraculous. And if you give it what it needs, it is going to trigger in your brain to stop eating. If it's not getting what it needs, it's not stupid enough to say stop eating. It's very intuitive. It knows exactly what you need. It relies on you to put it in there. And if you're eating just a bunch of crap and you're not nourishing and you're actually not eating properly, you're going to constantly get false senses of hunger because it's desperately trying to draw you back to food so that it can get what it needs. So I teach everybody how to really get proficient with a couple of hormones, ghrelin and leptin, our hunger hormone, our satiety hormone. How do we eat in a way that gets that system perfected? How do we eat in a way to control our blood sugar without the medication helping? And that really is always going to be protein first. So this is really what I teach in the protocol is people really getting their head wrapped around building their meals around protein. Protein is a macronutrient that is naturally a satiety macronutrient. It definitely triggers satiety before a carbohydrate would. I like to pair that with a good serving of fat because it helps you feel fuller, faster, for longer. It also helps better control your insulin. And then your whole plate is the rest of the plate is full of veggies, right? So I teach this in the protocol, and that's really important. No less than 30 grams of protein at a meal. You're trying
Can I interrupt for a second?
Yeah.
At what size of a person?
I was getting ready to say, no less, no matter what your size is.
Okay.
But you do need to take into account that me being the size that I am and you being the size that you are, female versus male as well, caloric needs are very different. Therefore, anywhere from 30 to 50 would be based on size and activity.
And there's a lot of conflicting information. When I was in school, it was 0.8 grams per kilogram of body weight, which we now know is just to maintain not dying, basically. Now there's some people saying you should get a gram per pound of body weight, a gram per pound of ideal body weight. What do you recommend on that?
Well, for one, it's very confusing because you just in a sentence went between kilograms and then pounds, and that's very confusing to a lot of people. So you have to understand that kilograms is the imperial system. It's not really a system that we use. When you get on your scale, you are weighing pounds, not kilograms. So let's say you weigh how much?
207 this morning.
So you would divide that by 2.2 to convert that to kilograms. Then multiply that by that 0.8 to get what the grams of protein that you should consume daily to not have a deficiency.
Right.
Okay. That's really what the RDA is all about, is let's just show everybody should be getting at minimum the 0.8. Really kind of a little bit outdated data. We are now really recommending between, let's say, 1.0, depending on how tiny the person is and how inactive they are, up to 1.6. That is grams per kilogram. Right. So again, you got to take your weight, divide it by 2.2, and then multiply that. The whole thing for, so much per pound ideal weight, that can get confusing, I think, because people don't understand it's not their current weight. It's what you should be ideally. And then people go, well, what should I be ideally?
That's why I don't like to talk to patients about that.
So I think it's better if we're talking accuracy to just teach people how to convert their weight to kilograms and then use that factor for that.
That's very easy. Again, so if you weigh round numbers, if you weigh 200 pounds, you divide it by 2.2, it's going to get you in the neighborhood of,
I don't know, Eric.
Splitting it in half.
What's 200 divided by 2.2?
Yeah, it's going to be like in that 192, something like that, or 92, something like that.
Don't ask me to do math without a calculator.
Young Eric, what is it? 90.90. Okay, so now 91, and that is your basic. If you don't want to die, you should be having if you're 200 pounds, you should be having about 90 grams of protein a day. But if you're like me and you're fit and active and you're trying to be anabolic, I try to be more in 1.5 grams.
What is anabolic?
Anabolic means in a positive state of growth. Catabolic means you're breaking down.
Nobody wants to be catabolic muscle.
Exactly. But a lot of people don't want to build muscle. But I'm just one of those dorky people who wants to build muscle. I just like it. Like to feel strong. So I try to get in that 1.5 grams per kilogram. So again, take your weight, divide it by 2.2. And then anywhere between 1 and 1.5 to 6 is the higher end grams per kilogram.
I would say the average woman needs probably around 100 grams a day of protein. So if you do 30, 30, 30. The thing I try to teach is that you should be balancing your meals properly at the meal so that you stay fuller faster for longer and you're not needing to snack between meals. It used to be, remember, we used to say 3 meals, 3 snacks. Well, all that's doing is giving your body a chance to spike its insulin and glucose. We don't want that. I want to teach everybody how to work with you should eat a balanced meal so that you stay full and you're not thinking about food all day. So that's the purpose of that protocol. That just gets into real quickly the nutritional and protein needs while you're on these medications. Now get into the importance and what people should be doing, because remember, your body is going to want to be breaking down protein to try to make up for, or breaking down muscle to try to make up for your deficit of calories, your deficit of nutrition, your decrease in fat. What can people do if they're just wanting to make sure they're not losing muscle? Like hold the fort, not necessarily build, but it's super important. And by the way, in my protocol, Dr. Rob has written a 6-week strength training program. So if you've never strength trained, it's a great program that takes you from a foundational level and then builds you up slowly to understand how to do it without getting injured. And that is embedded in my protocol. So when people purchase my protocol, they get that 6-week program in there.
Yeah.
But tell everybody right now when they're listening.
So first off, women, you are not going to get bulky lifting weights, okay? I get that all the time. I train some people still, and to a woman, they all say, no, I don't want to get big and bulky. Well, I have news for you. You don't have the hormones to get big and bulky unless you're taking copious amounts of steroids and testosterone. So don't worry, women, about getting big and bulky. You want to get lean and you want to get strong, and basic foundational strength training is going to do that for you. So we're going to
Can I add something?
Yes.
Lean meaning, because I know what women are thinking. Lean means you're adding lean muscle mass.
Yes.
Not that you want to aesthetically look in a way, but I will tell you, when you add lean muscle mass, it does help.
shape you.
Yeah. Metabolic spanks is what I call.
In a good way.
In a good way. But anyway, sorry. I just want to interject.
So the program basically starts out with foundational work, teaching you how to move right, mobilizing what needs to be mobilized, stabilizing what needs to be stabilized, and then doing basic movements like goblet squats, like lunges, like pushing and pulling, multi-joint movements that use lots of different muscles in various movements to the point of fatigue. I always write in my programs, your last 3, 4, 5 reps should be very challenging. Not to the point where you're struggling and your form sucks, but to the point where it's very challenging, where you're on your 4th and 5th rep and you're going, oh, I can't wait to put this weight down because I'm so tired. That's going to stimulate a growth response. You have to physically, microscopically tear muscle tissue so the muscle tissue repairs and it builds back a little bit stronger. It's called hypertrophy. You're not going to get big and bulky from it, but you're going to maintain muscle mass by stimulating that way.
So if I'm sore, is that why I'm getting sore?
That's exactly why you're getting sore. You're getting an inflammatory response from the torn muscle tissue. If you look at it microscopically, you literally have torn muscle tissue. And then inflammation kicks in. And then you have something called satellite cell formation, where satellite cells come in and they stimulate a protein synthesis that grows the muscle. That's how we build muscle. Now, this is why we don't want to take ibuprofen when you're sore. Because if you take ibuprofen or Aleve or anything like that from muscle workout soreness, not pain, but muscle workout soreness, you're hindering the physiological process we need to actually build muscle.
Right. You and I have talked a lot about how inflammation is not a good thing.
This is the good inflammation.
This is the good inflammation.
This is localized inflammation we need for repair. Now, 3 to 4 days a week as well. Okay. It's not 1 day a week. It's not 2 days a week. It's the main suggestion for longevity is 3 to 4 days a week of weight training, resistance training with weights. It's the same thing for being on a GLP-1. You have to stimulate muscle growth that way.
Yeah. And, it's important for people to understand that the protein that we're talking about people eating to offset the muscle, the reason we're saying that is because when your body doesn't have what it needs, it's going to take from your muscle and break down the muscle to get its energy. If you are consuming, so protein is just made up of 21 amino acids, and those amino acids are the building blocks for muscle. So that's why those two need to be coupled together.
Absolutely.
Okay.
Absolutely.
All right. So we've talked about what it is. We've talked about dosing. We've talked about the history of it. We've talked about the clinical benefits. We've talked about the importance of how it's used properly, which is with education. Please, if you know anybody who is on one of these GLP-1 agonists, please send them to my website so that they can get the education they need. I work with a lot of people individually on, let's say hypothetically you go through all of my protocol, the 31 videos, and I guarantee you're going to learn a ton. However, you need some help individualizing it. I do see people to individualize, their experience.
Okay, so all things GLP-1. So if you have any questions, shoot them over. pretty hot topic nowadays, and I'd say thumbs up or thumbs down from Shannon, the dietitian.
Absolutely thumbs up if it's done in the right way.
Okay.
I do see a lot of benefit in these compounding doses. I do believe that when we see people who are having extensive side effects, that it's because they're being overdosed. And the pre-filled pens are the pre-filled pens, whereas the compounding gives us the ability to really individualize and target dose certain people for certain reasons. We're going to start seeing this more and more, the neuroprotective stuff for dementia and Alzheimer's. This is just the beginning of what we're getting ready to see. However, for weight loss, I do believe it can be a great tool if you do it the right way. And the reason why I created my protocol was to help people, because people who are taking this need to have that education. And there's only one of me, and that was my way of trying to help as many people as possible.
There you go. All right. Well, there you go. Episode number 10 wrapped up. Good job. Smarter than me as always. I am Dr. Rob. I'm your guy from the outside in. That's my awesome wife, Shannon.
And I'm from the inside out.
So until next time, get better, not older.